Ladies and gentlemen, good afternoon. My name is Ton Lisman from Groningen in the Netherlands, and it's my pleasure to talk to you today about thrombin generation and whole blood thrombin generation in patients with liver diseases. And I would like to thank the organizers for inviting me to participate in this meeting. As you've heard from the previous presentation by Dr. Le Breton, patients with liver disease are in a hemostatic rebalance. So if this is the hemostatic balance in a healthy individual with a stable balance between pro and anticoagulants, this is the balance in patients with liver disease. So patients with liver disease are in a hemostatic rebalance because of a simultaneous decline in both pro and anticoagulant proteins. Now, the concept of rebalanced hemostasis has been largely generated using data from patients with relatively stable disease. I will talk to you today about patients that are critically ill and investigate whether this hemostatic rebalance remains in these very sick patients. So I'm going to talk to you about critically ill patients with liver disease, and I'm going to talk to you about three different categories of patients. Patients with acute decompensation of cirrhosis. These are patients with chronic liver disease with an acute complication that requires hospitalization. And these complications may include bleeding, encephalopathy, ascites, infection, or something else. Patients with acute and chronic liver failure. These are patients, again, with chronic liver disease and a decompensating event, but these patients also develop multiple organ failure. This particular condition is associated with high in-hospital mortality. And finally, I will talk to you about patients with acute liver failure, and these are patients without an underlying liver disease that suddenly and acutely develop major liver injury, for example, by toxins. Acetaminophen or paracetamol overdose is a classic example. And again, acute liver failure is a disease that is associated with high in-hospital mortality or requirement for liver transplantation. So I will investigate with you today whether these three conditions are also associated with a rebalance in hemostasis, or whether the hemostatic system turns towards either bleeding or thrombosis in these very sick patients. This table shows you an overview of the hemostatic changes in patients with mild disease compared to these critically ill patients. And these are median values of studies that we have done in my laboratory. So as you can appreciate, patients with acute and chronic liver failure particularly have decreases in platelets and fibrinogen. Formalin factor is already elevated in patients with mild cirrhosis, but substantially elevated in the sicker patients, both in acute and chronic liver failure and acute liver failure. Plasma levels of hemostatic proteins, including antithrombin and protein C, are relatively well preserved in patients with mild disease, but really are tremendously decreased in patients with acute illness. And some of these factor levels really go down towards zero, as you can see with protein C levels in patients with acute liver failure. As a result of these changes in the levels of plasma proteins involved in coagulation, the INR increases. So the INR is relatively normal in patients with mild disease, but elevated in patients with acute and chronic liver failure, and substantially elevated in patients with acute liver failure. So I will start with talking to you about the hemostatic system in patients with acute liver failure. So patients without underlying liver disease that get an acute event leading to necrosis of massive amounts of liver tissue. So acute liver failure is a rare disease, and data have been accumulated by the Acute Liver Failure Study Group in the United States that have collected data on a large number of patients over a large number of years. And shown here are results of a study on bleeding in acute liver failure. So this is a study of more than 1,700 patients, and this study actually showed that both spontaneous and post-procedural bleeding is actually rare in these patients. The vast majority of these bleeds are spontaneous upper gastrointestinal bleeds that are relatively mild in their nature. So bleeding is rare and usually mild, and almost never a direct cause of death in these patients. So bleeding is rare despite the fact that they have substantial abnormalities in their hemostatic system, including the substantially prolonged INR, as I just showed. So bleeding in acute liver failure is associated with a decrease in platelet count, but not with changes in the INR. So these are platelet count and INR measurements over the first week of admission. And you can see that there's no difference in the INR between patients that did or did not bleed during this first week, but platelet counts were substantially lower in patients that bled. So then the question is the decrease in platelet count responsible for the bleeding event? And there's data to suggest that this is not the case, so that the decrease in platelet count does not directly lead to bleeding. Because bleeding in patients with acute liver failure seems to be a manifestation of systemic inflammation. And these upper gastrointestinal bleeds that are relatively common, they're known in literature as stress-related mucosal disease, so related to inflammation rather than to hemostatic failure. And indeed, patients that bleed, as shown in this table, more often have abnormalities in markers of the systemic inflammatory response syndrome. So they are more often abnormal as scored by these systemic inflammatory response syndrome criterion. And also bleeders have more often systemic complications such as renal replacement therapy or the use of vasopressors. And indeed, there's a link between systemic inflammation and the extent of thrombocytopenia. So shown in this graph is the number of positive components of the systemic inflammatory response syndrome versus the platelet count over time. And as you can appreciate, the more positive for this systemic inflammatory response syndrome patients are, the lower their platelet count. So the relation between platelet count and bleeding might be mediated by the effect of systemic inflammation on the platelet count. So in summary, bleeding is uncommon in patients with acute liver failure and usually clinically insignificant. And this is maybe quite surprising because of these fast hemostatic abnormalities that are seen in these patients. Bleeding is associated with the platelet count and not the INR, but the thrombocytopenia might not be the cause of the bleeding. So as I showed, the thrombocytopenia is proportional to systemic inflammation and probably reflects the effects of inflammation on platelet activation and subsequent platelet clearance. So why do patients with acute liver failure bleed so rarely despite of these profound hemostatic abnormalities? Well, the answer probably is, like in patients with more stable liver disease, in compensation of defects in pro-hemostatic processes by defects in anti-hemostatic processes. For example, like in patients with stable chronic liver disease, in acute liver failure, there's a substantial imbalance in the forwardment factor at MTS13 system, with substantially elevated forwardment factor level in patients and substantially decreased levels of the forwardment factor regulator MTS13, with levels close to zero in some patients even. So we propose that this forwardment factor MTS13 imbalance compensates, at least in part, for the low platelet count in these patients. Shown here in this graph, in these graphs are data from 50 patients that we studied a number of years ago. But very recently, we've confirmed these data in a cohort of more than 600 patients, as identified in this reference. If we then look at thrombin generation in patients with acute liver failure, here performed by thrombomodulin modified thrombin generation, we see that patients with acute liver failure generate as much thrombin as healthy controls, despite their abnormalities in coagulation proteins and their INR. We think that this reflects a simultaneous decrease in pro and anticoagulant factors, just as the simultaneous decrease in pro and anticoagulants in patients with stable liver disease leads to normal thrombin generation. Again, these are data in 50 patients recently confirmed in a much larger cohort of 600 patients. And finally, there's a profound hypofibrinolytic state in acute liver failure. So in this plasma-based clot lysis assay, the vast majority of patients do not lyse at all in the 3 hours that this assay is run. So there's normal thrombin generation, but a defect in clot breakdown. So there's even hypercoagulable elements in the hemostatic status of patients with acute liver failure. And then a very similar picture is seen when you test not in the plasma compartment, but in whole blood. So these are results of thromboelastography testing, so viscoelastic tests in whole blood in 50 patients with acute liver failure. Their INR is substantially elevated. 50% of these patients have acetaminophen or paracetamol overdose. If you do these thromboelastography tests, you see that 2/3 of all patients have all parameters within the normal range. So despite the defects in coagulation and hemostasis, whole blood clotting results are essentially normal. 8% of patients even have a hypercoagulable profile. The interesting and perhaps confusing thing is that if you test not with thromboelastography, but with a different viscoelastic test, a ROTEM, that you get a different conclusion. So this is a very recent study, again from the acute liver failure study group in the United States. And this study found that in patients with acute liver failure, there's abnormal ROTEM parameters that are frequent and proportional to severity of disease. So a very different conclusion to that of TEG. However, this paper again states that whether the increased bleeding risk is associated with abnormal ROTEM indicates hemostatic failure or is a proxy for the disease severity requires additional studies. So again, we don't know whether abnormal ROTEM really predisposes to bleeding. I will come back to why we think there's a difference between TEG and ROTEM results in liver disease patients in a minute. So in summary, there's evidence of hemostatic rebalance in acute liver failure where the decreased platelet count is balanced by the unbalanced formalin factor LMTS13 axis. There's a simultaneous decline in pro and anticoagulants that has a net neutral effect, so normal thrombin generation. And there's even hypercoagulable features, including a hypofibrolytic state. And if you test by whole blood TEG, some patients are even hypercoagulable. And this rebalanced hemostatic status in patients with ALF really reflects what we see in the clinic. Bleeding is rare, as I showed, and in some clinical series, thrombosis is even more frequent than bleeding, which may be counterintuitive based on the results of routine tests of hemostasis like the platelet count and the INR. So then on to the hemostatic status in patients with cirrhosis and acute illness, so acute decompensation of cirrhosis and acute and chronic liver failure. There's actually little laboratory data on the hemostatic status in these patients. And there's also little data on the actual risk of bleeding and thrombosis in these sick hospitalized patients. In acute and chronic liver failure, so these are patients with multiple organ failure on intensive care that may develop also complications such as sepsis. There's very little data on the contribution of liver failure to the hemostatic changes versus the contribution of multi-organ failure and sepsis, because we know that patients with multi-organ failure and sepsis, in the absence of underlying liver failure, also develop tremendous hemostatic changes. And this recent paper from my group has investigated the hemostatic status in patients with acute and chronic liver failure and compared it to patients with sepsis without underlying liver disease, and actually concluded there's tremendous overlap in hemostatic status between those two disease entities, suggesting that the hemostatic changes in acute and chronic liver failure are not only driven by liver failure, but also by their critical illness in more general terms. So the primary hemostatic system in patients with acutely decompensated cirrhosis and ACLF is again balanced out by an unbalanced formalin factor LMTS13 axis. So in these graphs, you see formalin factor and LMTS13 levels in healthy controls, patients with stable cirrhosis, patients with acute decompensation of cirrhosis, and patients with ACLF. And you see a stepwise increase in formalin factor and a stepwise decrease in LMTS13 levels proportional to severity of disease. And again, we propose that these high formalin and low LMTS13 levels compensate, at least in part, for the thrombocytopenia of these patients. If we perform whole blood, if we perform plasma-based thrombin generation assays modified by thrombomodulin, we find that these patients are hypercoagulable in comparison to healthy controls. So patients with acutely decompensated cirrhosis and patients with ACLF make more thrombin in thrombomodulin modified plasma-based thrombin generation tests in comparison to healthy controls, despite the fact that they have low levels of coagulation proteins and an elevated INR. The fibrinolytic system in sick patients with chronic liver disease is very mixed. So there are patients both with acutely decompensated cirrhosis and with acute and chronic liver failure that have accelerated lysis in a plasma-based clot lysis assay. But there are also patients, particularly in acute and chronic liver failure, that have inhibited fibrinolysis. These patients with very long plasma-based clot lysis assays are those patients that are also septic. And we also know that patients with sepsis without underlying liver disease have inhibited fibrinolysis. So a mixed fibrinolytic pattern in these patients. If you test patients with acute decompensation of cirrhosis or ACLF in whole blood viscoelastic tests, ROTEM or TAG, you find again that in ROTEM these patients are normal or hypocoagulable, and these are this table shows ROTEM results in which you can see that the abnormalities in ROTEM are more pronounced in ACLF compared to acutely decompensated cirrhosis. So the sicker the patients, the more abnormal the ROTEM test results. But again, there's a difference in thromboelastography test results because these are, in essence, normal in these patients. And this very much resembles what we've seen before in acute liver failure. So we see in these patients with critically ill cirrhosis, enhanced thrombin generation, but normal to hypocoagulable viscoelastic whole blood tests. So which test should we trust, and how should we interpret the difference in these results? So obviously the advantage of whole blood viscoelastic tests is that they're performed in whole blood. So you take the contribution of cells into account, and thrombin generation is usually performed in platelet poor plasma. However, as we've seen in my talk and also the talk by Dr. Le Breton, thrombin generation tests can be modified by thrombomodulin to include the anticoagulant action of the protein C system. And this modification has not been applied in viscoelastic tests yet. So the absence of thrombomodulin in whole blood tests leads to an underestimation of true hemostatic potential because we lack the effect of the protein C system. And we know that components of the protein C system are also present in decreased concentrations in patients with liver disease. In whole blood viscoelastic tests, the hypocoagulable state is primarily driven by a low platelet count. But we know that viscoelastic tests are insensitive for von Willebrand factor that we have seen compensates in part for the low platelet count. So again, this leads to an underestimation of true hemostatic potential in whole blood viscoelastic tests. Now, the difference between TAG and ROTEM likely depends on the strength of the initiator. So the strength of the initiator is much less in TAG. So it takes longer for a clot to form in TAG-based assays than in ROTEM-based assays, which are quicker. So in TAG, there's more time for the anticoagulant system to kick in. So the TAG, in essence, is more sensitive for the anticoagulant system. And we think that explains why TAG is more often normal in patients with liver disease compared to ROTEM, which is more driven by the pro rather than the anticoagulants. So we decided to perform whole blood thrombin generation tests in critically ill patients with liver disease because this may represent the best of both worlds. The inclusion of blood cells, but also the possibility to include thrombomodulin to include the anticoagulant action of the protein C system. So we performed whole blood thrombin generation in a mixed group of critically ill cirrhosis patients in the absence and presence of thrombomodulin. So these are typical thrombin generation curves that we got, and you see a tremendous difference between healthy controls and patients with liver disease. So these patients with liver disease take longer for the first thrombin to be formed, and also the rate of thrombin generation is lower. However, the area under the curve seems quite similar in patients with liver disease compared to healthy controls. And indeed, if we quantify this, the ETP is more or less the same in patients and controls, but the peak thrombin and the lag time are really different between patients and controls. So the peak and the lag time suggest a hypocoagulable state, whereas the ETP suggests normal coagulability in patients. So we performed whole blood thrombin generation in the absence and presence of thrombomodulin. So the absence in the top panels and the presence in the panels on the bottom of this graph. And the interesting thing is that we observed that whole blood is actually tremendously resistant against the anticoagulant action of thrombomodulin. So the ETP in healthy controls only decreases by about 10% or so, by a concentration of thrombomodulin that is much higher than the concentration of thrombomodulin that we use in plasma-based assays. And indeed, we also performed thrombin generation experiments in plasma in the same patients. And there we see, if we perform thrombin generation in the absence of thrombomodulin, that patients make less thrombin than healthy controls. But if we add thrombomodulin, thrombin generation in controls is inhibited tremendously, and thrombin generation in patients is inhibited less because of the lower concentrations of protein C in patients. And if we then compare thrombomodulin modified thrombin generation, patients make more thrombin than controls. So there's a difference between thrombin generation in plasma and thrombin generation in whole blood, which is in part explained by the fact that whole blood seems to be resistant to the anticoagulant action of thrombomodulin. So the whole blood thrombin generation assay is very sensitive for blood cells, as shown here. So there's a good correlation, particularly with peak thrombin levels, with the platelet count and the hematocrit. Stressing that whole blood thrombin generation really takes the contribution of blood cells in the process of thrombin generation into account. So is there really an advantage of whole blood thrombin generation assays compared to the plasma-based assays that many of us use? Well, there's pros and cons, I think. Whole blood thrombin generation potentially is a bedside test that may compete with whole blood assays such as TEG and ROTEM. There's a major role of platelets, but also of red blood cells in the process of thrombin generation. But the downside is, again, that the whole blood thrombin generation assay is not sensitive for Willemand factor, which we think compensates in part for the low platelet count. So here also, it may be that the whole blood thrombin generation actually underestimates true hemostatic potential. The thrombomodulin resistance in whole blood is not completely understood. Scientists at CNOPS are currently working on this. I think it's important to better understand this, to better be able to interpret whole blood thrombin generation test result assays when performed in the presence of thrombomodulin. So as I showed in one of the previous slides, this thrombin generation assay is only the procoagulant part of the thrombin generation curve. So we miss information in whole blood thrombin generation assays as compared to assays that we perform in plasma. And this may also be a downside. So in summary, ladies and gentlemen, I hope to have convinced you that there's a hemostatic rebalance in very sick patients with liver disease, both in patients with underlying cirrhosis, but also in patients with acute liver failure. And this rebalance is due to a concomitant decline in pro and anti-hemostatic drivers. I've shown that bleeding is very rare in ALF, despite the tremendous hemostatic abnormalities we see. And there's work to be done in cataloging the bleeding and thrombotic risk in patients with acute and chronic liver failure and patients with acute decompensation of liver disease. And in all these conditions, thrombin generation appears to be preserved despite these major changes in levels of coagulation factors and changes in the INR.